Good afternoon, ladies and gentlemen, and thank you for joining this special COVID-19 marathon webinar, which we are able to deliver today, thanks to the willingness of many intensive care specialists across the world who are ready to speak to us despite their heavy work schedules and also due to the generous support of our industry partners, which has helped us to bring this live broadcast and learning opportunity to so many. Since the initial outbreak of the novel coronavirus in Wuhan, China, late last year, and the WHO declaration of this situation as a public health emergency, the lives of ordinary citizens, the responsibilities and priorities of governments, and the work of healthcare professionals across the world have all been transformed by this deadly virus. We know that people are scared as they watch the extraordinary and upsetting images on their screens and see the daily numbers of those affected and sadly dying rising steeply. We can appreciate their feeling of helplessness. Our ICUs are facing the greatest challenge of recent decades, and sadly, many health workers in the front line have also contracted the disease while trying to save the lives of others. We are, however, in this together, and we'll face this battle together. Saving lives is, as it always was, our number one priority. We must, however, also look after our own health and well-being, and this is why it is so important that the support and the resources are in place. For this reason, the European Society of Intensive Care Medicine has been actively publishing guidelines and scientific articles, increasing public awareness and supporting its network of intensive care professionals. One way to connect everyone is through online forums like this, and the next 7 hours will be filled with back-to-back presentations and live interviews with leading international experts from China, the US, Latin America, South Africa, and Europe. They will be sharing with us latest clinical evidence, data, and best practice, and answering questions from the audience. Before we begin, I will briefly introduce myself. I am Joseph Kesicioğlu, Head of Intensive Care Medicine at the Department of Intensive Care Medicine, University Medical Center, Utrecht, and also President of the European Society of Intensive Care Medicine. It was the end of February when our President-elect and my friend Maurizio Cecconi called me on a Friday afternoon telling that something important was happening in Lombardy, Italy, with regards to COVID-19 patients. On the 5th of March, we decided to send the warning to everyone in the world, sharing the experience from Milan.
Dear friends, at this moment in time, we believe it is important to share our first impressions and what we have learned in the first 10 days of the COVID-19 outbreak. We have seen a very high number of ICU admissions, almost entirely due to severe hypoxic respiratory failure requiring mechanical ventilation. The surge can be important during an outbreak, and cluster containment has to be in place to slow down virus transmission. We are seeing a high percentage of positive cases being admitted to our intensive care units, in the range of 10% of all positive patients. We wish to convey a strong message. Get ready. We also want to share with you some key points from our experience. Get ready now, with your ICU networks, to define your contingency plan in the event of an outbreak in your community. Don't work in silo. Coordinate with your hospital management and other healthcare professionals to prepare your response. Make sure your hospital management and procurement office have a protocol in place about which personal protection equipment to stock and restock. Make sure your staff is trained in donning and doffing procedures. Use education, training, and simulation as much as possible. Identify early hospitals that can manage the initial surge in a safe way. Increase your total ICU capacity. Get ready to prepare ICU areas where to cohort COVID-19 positive patients, in every hospital if necessary. Put in place a triage protocol to identify suspected cases, test them, and direct them to the right cohort. Make sure you set clear goals for care with patients and their families early on. With our best regards.
I would now like to introduce Professor Maurizio Cecconi, who will be acting as a moderator for the sessions throughout the day. Maurizio is a full professor of anesthesia and intensive care at Humanitas Research Hospital and University in Milan, Italy, and president-elect of the European Society of Intensive Care Medicine. He will begin his mandate as president in October 2020. As the first Western country to face the COVID-19 outbreak outside of China, the world's attention and media focus has been on Italy, and Maurizio has given several interviews to the international press. He is part of the COVID-19 Lombardy ICU network, a task force set up by the Lombardy government and local health authorities to lead the response to the outbreak. He is also co-author of the critical care utilization for the COVID-19 outbreak in Lombardy, Italy, early experience and forecast during an emergency response. Good afternoon, Maurizio. Welcome. How are you doing now?
Good afternoon, Joseph. Well, it is still tough here, but we are good, Joseph. Thank you. How are you?
Okay. Well, we have started actually 1.5 weeks ago, and our patients are also indeed increasing, and we have more than doubled our ICU beds as of now.
Yeah, I think that's what we're seeing now. We do hope, and I'm sure that some of the speakers will tell more about the Italian situations later. But we do hope that we are seeing the peak coming, and finally we can start to breathe a bit, because it has been quite difficult. But anyway, since you give me the words, I would like really to thank you also as a friend, as a president, because you listened to me, to us very carefully, and we decided as ESICM to take the lead in trying to spread information and knowledge and listen to our members worldwide. So thank you for that. And I think the affection that we get from everyone and the support that we got from everyone when we started to do our first pages, blogs, and the live webinars has been so overwhelming that it's been great to see that we could prepare this live event today. And I just would like to thank our office and to thank also everyone, the technical people, everyone that has been working on this, because, the world has changed in a month. Everyone is trying not to meet in person. We are trying to bring people together in a new way. The amount of work that we put together on this has been enormous. We hope it's going to work. I would like to thank the sponsors that have supported us. I would like to thank also the speakers, because everyone is really busy on the front line, and to take some time really to be able to be here, it means that every one of our teams in our hospitals today is working a little bit harder. So I would like to thank everyone on that. And also, we need to remember really that if we have any technical issues, we do have a backup. So we have worked around the clock to be able to record some of the talks this morning. And so don't worry if by any chance there is a problem with any of the videos or any of the connections, you will be able to follow some material that we've prepared in the last few hours. So we want to make this interactive. Our social media team is online, ready to get questions, and Joseph, myself, and other moderators, we will be able to do that. However, before I give you the word back, Joseph, to introduce the first session, as we were discussing before this morning, I think it's important to remember that at the moment, roughly 28,000 people across the world, both young and old, have lost their lives to the virus. And also some extraordinary healthcare professionals who've been caring for patients with the virus, working on the front lines, unfortunately have not been spared. So I think we would like to ask everyone just to stop for a few seconds to remember all that have died in this struggle, the many victims, and in this moment, I would say, especially our dear colleagues and friends. We think really of those left behind, many of whom have been our patients, our healthcare professionals, our colleagues in the hospitals, our patients in our intensive care unit. So I would just like to stop for a few seconds. Okay, I think Joseph probably is now time to start with our first speaker.
Yes, thank you. Our first guest today is Dr. Janet Diaz of the World Health Organization, who is the clinical management lead for COVID-19, and she was involved in supporting various aspects of the WHO response to Ebola. She will be talking to us about the scale of the COVID-19 pandemic and the role of the WHO, and has kindly offered to take questions from the floor afterwards. Please.
Good afternoon, good morning, good evening. Many thanks. I hope you can hear me okay. It is a privilege for me to be here, and I want to thank the organizers of the conference for giving us the opportunity to present at this very important Congress. As well, I want to say thank you to all of you for the hard work that you're doing on the front line. You know, my background is as an intensivist, and so I know the difficulties and the challenges you are facing, and we are together. I want to cover 3 points in this discussion: give you a global surveillance update, discuss about the concept of operations and our approach to the COVID-19 pandemic, and discuss a bit of work about accelerating innovation. Between the 31st of December to March 26th, there was a total of 465,915 cases reported to WHO, affecting 209 countries, with a total of 21,031 deaths from 99 countries. And the top 10 countries with the highest number of cumulative cases are listed here, including China, Italy, USA, Spain, Germany, Iran, France, Switzerland, the UK, and the Republic of Korea. On a daily basis, we get the information of new confirmed cases around the world. And as of the 26th of March, you can see here, there was 40,486 new cases from 193 countries, 5 of which were just reporting their first time. Those include Belize, Dominica, Turks and Caicos Islands, Myanmar, and the Lao Democratic Republic. That day, we also saw 1,710 new deaths from 48 countries. And the countries with the highest number of new cases, similar to the list I described before, include United States, Italy, Spain, Germany, France, Iran, Switzerland, the UK, Austria, and Brazil. You see on the left is a map, a global map of the daily new confirmed cases, highlighting in the darkest colors which countries are seeing the highest numbers. This slide shows the number of confirmed cases that the IHR, so that's the International Health Regulations, that's how information WHO gets its information from member states. And here showing the epi curve over time. The highlight of this curve is that it is separated by regions of the world that the WHO uses. So at the beginning, the predominance of cases in the Wipro region, predominantly in China. As you come to see here, you could start to see the blip of increased cases in this more orange-red area, and that represents the European region where we are today. All along, you see a small number of cases in purple. This is in the EMRO region. The yellow region starts when we start to see cases in the PAHO region, so the Americas. And you see the increase in cases over time in the yellow. And I want to highlight this green here, and you can barely see it on this graph, but these green is really the cases in Afro, so the big continent of Africa, very little reported cases over time. On the right, I want to show you a graph from the colleagues in Spain. The reason I present this graph is just to show you the rise in number of cases, because this is what many of you have been seeing in your countries, specifically in Italy, in Spain, in France, and in US, and was seen in China. So a rapid escalation of new cases every day, and at the same time reflected a rapid escalation of deaths every day. And we know in the middle between the number of cases and the deaths is a lot of intensive care bed use, a lot of patients, a lot of doctors caring for those patients, and a lot of resource use and perhaps exhaustion of resources. These two graphs give you a cumulative number of reported COVID cases per population. Again, on the left, showing you in the denser colors, the more COVID cases per population, highlighting the differences across the globe. And to the right is just a little snapshot of total tests performed per million people, again, looking at the differences in testing per population or per number of persons and the variability around the world. So of course, that raises questions as to why in Africa or sub-Saharan Africa, there is few number of cases, perhaps because the ability to test is not as robust as it can be, as it has been in other countries, for example, such as here in the Republic of Korea. So what is our concept of operations? So I think number one is the public health interventions. And I'm going to try to rapidly go through a concept of operations that focuses more on the clinical operations because of the audience that we're in. But I think from what we know of the experiences around the globe, that public health interventions are by far very important and effective to flatten the curve. And I don't have a picture of the flattened curve, but but the main points from this slide are, obviously here is introduction of the virus, here is early detection and local transmission, and this amplification phase can take different curve designs, in the meaning that it can be very accelerated with a doubling time between 2 and 3 days, which some countries have seen, or a more delayed doubling time between 4 days, 5 days, up to 7 days, which countries have also reported when they implement public health interventions. So the containment is important, and I think everyone would agree it's the only way to delay the upsurge of patients that require acute care, hospitalization, and intensive care. So what are these public health interventions? They are to do active case finding. So for those countries that are just at the beginning, it is important to find your cases. It is important to isolate your cases. And we'll talk more what this means operationally in the next slides. It is important to test your suspect cases. And of course, this is all with the caveats that we know that there's not enough diagnostic testing to test all patients, all suspected patients everywhere at all times. But for the public health interventions to work, this is still, the best approach. And then contact tracing. And again, understanding the caveats that in certain situations, such as when there's widespread community transmission, contact tracing can be nearly impossible to do. But the public health intervention to stop transmission, as in all other outbreaks of highly infectious diseases, is to contact trace, to monitor, and in this case has the recommendation to quarantine of contacts. As public health interventions get put into place, unfortunately, the speed of the epidemic has passed from different scenarios. It passed from scenarios to countries where there's only a few countries now that have no cases. It passed to scenarios where we have one case, sporadic cases, or low number of cases and maybe small clusters. Progressed to large clusters, which rapidly progressed into widespread community transmission in certain provinces, as you've seen in northern Italy, in France, in Spain, in Iran, and US. So what does this mean for now? What does it mean for the countries that are still getting ready or preparing or are in the middle of the surge? The concepts are relatively simple. We know the severity of disease by best estimates, again, and this is best estimates from the largest cohort studies from China, that the predominant majority of patients have mild disease, so 40% with mild disease, so very little needs for any acute care hospitalization. The next portion with moderate disease, meaning they probably have some radiographic infiltrates, but not severe pneumonia, so pneumonia that can likely be managed on an outpatient setting. Severe patients, which have physiological changes that require acute care intervention, such as oxygen therapy. And then the critical patients that require intensive care, commonly mechanical ventilation. So the severity of disease looks like this, but the resource requirements, which is what we're seeing in the situations when countries are in full surge, is a wide impact on the need for intensive care beds, for ventilation, for acute care with oxygen therapy. And of course, these proportions are estimates that we learned from China, but they will depend on testing. In China, where they tried to test almost everyone that had some symptoms, and were suspected, although they didn't do that for the entire outbreak, but they did it for most of the outbreak. These are the proportions. If you're in a country right now where you're not able to do that testing, the denominator will be different and the proportions may look different based on the subset of patients that you are testing. So what does getting ready mean? And we've tried to kind of keep this to the basics. Some countries have more experience with outbreaks of infectious disease, and some parts of Africa actually have built up these systems robustly, even some of the most resource limited settings, because they are used to having outbreaks of infectious diseases, where other countries, some of our countries, perhaps less used to having the outbreaks of infectious disease. But what is important is screening and triage at all access points of the healthcare system. That means everyone has to be educated and know how to screen for a COVID suspect patient. And a triage system has to be in place that uses some standardized scoring system to evaluate severity of disease. That's point number one. Point number two, I think what's been most useful in this outbreak, and many countries have done this in different ways, is the COVID-19 informational line. That is important in order to direct the public, because the community needs to be educated and the community needs to know what to do and the community needs to know that they're safe. So where should they go? Should they go based on the type of symptoms they have? Where should they go for testing, if the testing strategy is to go get tested? Or where should they go for treatment if they actually have signs of severe disease? So this information line and referral pathways have to be put into place and ready to go, including the inclusion of transfer vehicles or ambulances to transfer patients to the designated testing or treatment areas. There has to be a plan as to what are your designated COVID centers for isolation and care for mild or moderate cases that are not at high risk. Will you choose to put them at home if home is a safe place for them to be and they can be in self-isolation? Or will you choose to put them in a community facility where patients can be held together, cohorted with people with the same diagnosis, and get their 14 days there, their care there, not requiring acute inpatient hospitalization? These decisions need to be made at the national, regional, local level to decide what is the right strategic approach, but the concept needs to be put into place. Designated COVID treatment areas. Many of you, I think, work in these areas right now that are caring for the patients with severe or critical disease in intensive care or on medical wards or infectious disease wards. And part of the readiness, the last one, is make your surge plan. And I think this is where we have seen that countries taking action at the right time to surge. I bring this graph again just to show the highlight how fast the rapidity of cases can grow exponentially when public health measures are not put into place or are put into place in a slow fashion, and how many deaths can increase with that. So meaning the load of patients you'll have to manage in hospital, in intensive care, and the patients that may die. So taking actions at the right time means that the surge plans have to think about the 4 S's or the 5 S's. Structure, so that means structure and beds. And so we go back to the basics. What beds can you repurpose from your hospital wards? What hospitals can you repurpose for COVID? Do you need to build new hospitals? What kind of hospitals? Military hospitals, tent hospitals? Who's going to build this? Staff needs to be kept safe. And I think this is something that's hitting home to everyone, acknowledging the Maurizio's moment of silence for the healthcare workers that have passed. So we must focus on, if we're going to, as we're going to surge, that we must keep our healthcare workers safe, and some may be better prepared than others because they've had more training in infectious disease or infection prevention and control than others. But it is our priority to keep them safe and focus on IPC measures and workflow. And so this becomes very important, as how health workers work in the COVID unit, where they don, where they doff, put on the PPE, take off the PPE, how they wash their hands, how they come into the facility and how they leave the facility. These are all important workflow interventions that need to be done very carefully and taught to the staff. You'll have expanded staff model systems, which I know many of you are doing, which means that you'll bring in people that have little, perhaps, or no intensive care expertise to come be physician, intensive care extension providers. So we have to focus on making sure that they stay safe and that we have the optimal use of evidence-based protocols in our units. And then, as has seen in some of the countries, the use of regional extra workforces, national extra workforces, including the military, global surge workforces, such as emergency medical teams or teams from China that may now be able to have some bandwidth to come and help another country set up, augment workforce, or set up a treatment unit, or set up a hospital. NGOs, and I know many of your humanitarian organizations, such as Médecins Sans Frontières, MSF, and DELIMA, are already helping and working here in Europe, in fact, to help surge the workforce. And WHO and its GORN partners that are also participating. Supply is a big ticket item here. So key items that need to surge for care, such as PPE, oxygen in certain settings, and ventilators. And again, what is your regional, national, and global surge plans for this? And finally, I add here a word about global solidarity, the word that our Director General, Dr. Tedros, likes to use. The need to open up humanitarian corridors for the most vulnerable countries that need supplies, equipment, and human resources. And as we know, the borders closed, that means borders closed to many other things. And the importance of getting the correct supplies and staff, especially to countries that are in conflict, to refugee communities, and low-income countries scattered around sub-Saharan Africa. What about clinical care? What's our operational plan for clinical care? So going to the patient now. So we started with the operations and setting up the system. Now we're back at the patient. So how can we provide patient-centered care and evidence-based care? And evidence-based care during times of uncertainty. And why uncertainty? Because there remains many things we do not know about the disease, although many things we have learned over time. I want to thank our colleagues at this point in China and all over the world that have spent not only time taking care of patients, but also doing clinical research and trying to answer some of these unknowns and publishing excellent studies, clinical studies, observational studies, starting to publish some randomized studies in order for us to improve our knowledge base so we can improve our practice. What we do know is that older persons and those with comorbid disease, such as hypertension, diabetes, and cardiac disease, are reported to have higher risk of death, but death has also been reported in younger patients, and we need to understand that better. We know that higher levels of D-dimer and SOFR scores have been associated with higher mortality, but we need to do more analysis and investigation to see what else predicts severity and death. We seem to have reports that children and pregnant women, their disease seems to be more mild, but critical cases have been reported. And as for complications, this has been consistent, perhaps because the case definition required pneumonia at the beginning, severe pneumonia being the common case complication, sepsis, and specifically acute respiratory distress syndrome, but also reported is cardiac injury, acute kidney injury, and again, the profiles of hospitalized patients and intensive care patients needs to be better described. What is missing? We need a better understanding of pathophysiology of disease progression. What is the inflammatory pathways that are activated, the coagulation pathways that are activated? This is important work in order for us to better develop our therapeutic plans, validation of predictors of disease severity that can maybe help us with early classification of disease, how to manage patients, where to manage patients, prognosis, family discussions, end-of-life discussions. What do we know about clinical management? There are evidence-based interventions that save lives from patients with ARDS, and these should be implemented. And I know I'm speaking to the people that know this the best, but I think as a standardized approach to management of COVID patients that are in hospital with pneumonia and ARDS, the basics, and do the basics well, and do that in all countries where there are resources and where there are limited resources. So this means early triage and recognition of severe cases and close monitoring, early initiation and escalation of oxygen therapy when indicated, and close monitoring. For those that get intubated, implementation of lung protective ventilation strategies for ARDS coupled with the best practices for sedation, prevention of complication and liberation from ventilation, prone position for moderate severe ARDS patients, and fluid conservative regimens. What we don't know, efficacy and safety of high flow oxygen and non-invasive ventilation. Specifically, the concern here has been about the extent of aerosolization of virus. So of course, if used, should be used with airborne precautions, and patients monitored closely to delay and not to delay intubation when indicated. And most recently, I'm sure you've seen the videos of using ventilators for multiple persons. And is that really safe? Is that a good idea? How to do it safely, how to optimize it? You know, what are the indications to do this? These are things that we must still answer. In regards to therapeutics, again, and this I think has challenged the community more than anything, is the evidence-based during times of uncertainty. There is no known effective antiviral or adjunctive therapy as of March 26, 2020. So the WHO recommends these repurposed therapeutics that are being used to be used under ethically approved randomized controlled trials that are the best way to assess efficacy and safety. And thankfully, to many colleagues around the world and many investigators around the world, there are multiple clinical trials ongoing and multiple randomized clinical trials, which is wonderful. And we encourage those be used to test these repurposed drugs, off-label drugs, in order to get an answer. What's concerning right now is really the widespread use of off-label therapeutics globally. And this is including a tremendous amount of polypharmacy between different drugs, whose risks are unknown when given together and potentially could be harmful, and also impact supply chain for other diseases for which they are on the market for. So this is an important consideration that we ask member states to look at as states start to develop national therapeutic protocols that are not based on evidence-based medicine. If you are using these off-label therapeutics and you are unable to use it in a clinical trial, the WHO has some guidelines about the monitored emergency use of unregistered interventions that describes that these may be used, but only when RCTs cannot be quickly implemented, and patients should be enrolled with informed consent, with National Ethical Review Board approval, and data be collected and analyzed on a regular basis. Accelerating innovation and research. Again, I applaud many of you probably as well that are ongoing, doing clinical trials, randomized trials for therapeutics or observational studies, collecting prospective data in order to inform our understanding of this disease and interventions that may save lives. In early January, the WHO held a global COVID research summit, which brought together many researchers to move forward on key topics. Out of that was a lot of work that has been done over time on a global COVID-19 clinical platform, which the WHO supports as a global registry for COVID-19 hospitalized patients to inform public health response. And when possible, that means when you're not so busy in the hospital, please try to contribute to this data platform. The other major push from the research group here at the WHO has been the Solidarity Trial, which is meant to be a multi-center, multi-country randomized clinical trial that launched just yesterday, I think, with its first enrollment. It is a global trial that is has multiple arms to test various therapeutics that have been prioritized by a global expert panel group. The WHO is also working on many streams of research not to do research ourselves, but to help prioritize the research questions with the global community and then facilitate that this research gets done and published quickly and shared to inform us. And the research is not just on clinical care, which I've been discussing, but on community engagement, social sciences, ethics, data sharing, infection prevention and control, and transmission and epidemiology. Accelerating innovation is not just about research. Actually, we need to figure out how to expand our innovation in equipment, which means diagnostics and biomedical equipment. How can we use innovation to improve the supply chain models, the production, from the production side to global dissemination in an equitable fashion to countries and frontline users. So the WHO has brought together UN agencies, public and private stakeholders, humanitarian partners, and academicians to deal with the global supply chain and how to accelerate innovation and distribution. The key focuses here, as you know already, are the personal protective equipment, the oxygen, which may not be limited in some of the countries here in Europe, but for low-income countries and many of sub-Saharan countries where local production is limited, this is a major, major, major problem. Biomedical equipment, I think the ones that seem to be, that are the most obvious being ventilators and consumables related to ventilators. And then of course, diagnostics. And again, as we work to improve the supply chain and the production of these key items, knowing that all of this, if it's meant to be used in the field, has to be used with appropriate training and standard operating procedures. So with that, I highlight some of the work that WHO has done on training. And these two, I think I relate the best to the audience that we're talking of now. This will be the clinical care of severe acute respiratory infection, talking about some of the basic principles of clinical management, and the severe acute respiratory infection treatment facility design. So how to repurpose your hospital, your ward, your unit, how to build a new treatment center according to IPC, infection prevention and control principles, and appropriate ventilation principles. And here a module on infection prevention and control, again with the focus on keeping healthcare workers safe. So in conclusion, I want to thank you all for giving me this opportunity to talk with you. I want to thank you all for all your hard work on the front line. I know it's not easy, but as Dr. Tedros has repeatedly said, only together in solidarity will we as a global community save the most lives, at the same time advance the science of public health and clinical care. And our common aim is to protect our community's health and happiness all over the world. And with that, I want to thank you for your attention, and I'm happy to take any questions.
Thank you very much, Janet. Indeed, there are quite a lot of questions. I will choose some of them. One of the questions was, you mentioned the standardization, but we also know that there are lots of variation in practice with regards to isolation and quarantine. Can you comment on that, and what's the role of WHO in this?
So I think it's a very good question, and I think a lot of this is in the meaning behind the message. So isolation, the recommendation to stop transmission is if you have COVID-19 that you isolate, you do not get close to other persons. Now the mechanism that you're going to do that depends on your setting. Initially, some of our guidance said, hospitalize everyone. And the reason it was like that, and I have to, give a disclaimer to that, and it is true in essence, because the idea was to put people in an isolation room so that they can not infect any other. But the truth is, we know that many health systems, most health systems, even the most robust health system, cannot manage to hospitalize all these patients because of the extent of numbers of patients. So then the idea becomes the isolation still has to happen, but it has to happen either at home, where you have where you instruct infected persons to self-isolate at home, and if that's possible, then that's fine, and that they're monitored, and that they have access to rapid medical advice if they have a symptom or a complication. The other option is to use a community facility, and this is like a repurposed gymnasium or a stadium or a school. And this may be better options in some communities where home isolation, because of the way communities may live, maybe too close together, too many people in one small home, then home isolation becomes impractical. So the community may, so the public health system may decide, let's make a community facility, and patients can go there and remain there. That's a similar thing to the quarantine. So the context for quarantine, is this possible? But the idea there is that contacts must be monitored closely. It could be a phone monitor. It could be a WhatsApp monitor. We can use technology to monitor them. And if they develop any symptoms, then test and refer to the right place. So again, so these concepts are the key concepts. And then the way you implement them or operationalize them, which is kind of why I presented this as an operational discussion, then we need to look at the details. Where is your situation and where is the best place to do this for your communities? Over.
Okay, I think Mauricio has a question. Mauricio?
Yeah, Janet, first of all, thank you so much. And also thank you to WHO for everything that you've been doing, because all the advice that you've been giving, I would say worldwide, has been instrumental for us, especially, I would say in Italy. For us, it became so clear from day one of the outbreak, you cannot win just in hospitals, you really have to contain the virus. So, it's really an important message you give and that we followed. My question is, as an intensive care society, we are trying to support also low and middle income countries. And that's, of course, it's a big challenge there, because if we work now with limited resources in rich countries with ventilation and intensive care units, the question that I have is, what can we do for countries like Africa, continents like Africa or other countries with low resources? And I'm sure that your public health measurements are going to be very important there. What can we do as a society or as a scientists or clinicians to help you with that?
Thank you, Mauricio. I think that the challenges in the low-income countries that have much less resources, maybe 2 ventilators in a hospital rather than 70, is a challenge. And from our side, what we would like I think it's a couple of fold, Maurizio, and this is something perhaps we can further discuss with time. One thing is, I think, immediate type of peer-to-peer knowledge exchange platforms, I think, are very useful. So I think what the society is doing with its webinars, speaking basic messages about, good practices for oxygen, for ventilation, maybe there won't be that many ventilators available, but those patients that do get them, that they get that quality ventilator management possible. So I think there's a role there for peer-to-peer knowledge exchange, information sharing from the society to those that are working in lower resource settings. The surge is a very important also operational way to share information, how you surged it. And of course, the systems look different, but what your decisions were to surge, to repurpose the ward, to how you brought in new staff, how you trained the new staff. These are things that are operational issues, but may be helpful to share that experience with the doctors or the clinicians or the administrators, I guess, also in these countries. And then finally, we don't know what will happen in Africa, and we're watching the epidemiological curves there. They will have a shortage of staff, and how we can provide more remote support is something that WHO is looking at. And at certain times, when I hope that the outbreak or the pandemic subsides in Europe, and if there was need for teams to go to other countries, so just like the Chinese teams have been able to go to other countries to support, that we would look for cross-country medical team support into some of the countries in Africa that maybe have the least resources and would benefit from an additional workforce that's able to take on a significant amount of clinical care with them. So those are just a few ideas, though, and I'm open to look for more opportunities for collaboration with this society and the bigger societies of intensive care. Thank you.
Okay, Janet, thank you very, very much, especially in this busy time that you have reserved some time of yours. And I think we can move on, Maurizio, to the next session.